a long time. I want to let Jan introduce herself, tell her anybody a little bit about herself, and then I'm going to take over for a while and we'll switch back.
Okay. Hi, everyone. I'm Jan Allen. I've lived all of my life on Long Island. I was, for a while, the president of my Huntington League and board member for housing and other issues. And then in the early 1990s, I served 4 years on the league board with people like Dare Thompson and Barbara Bartoletti, who recently retired after a long career in legislative advocacy. And that's actually the field that I've worked in for many years, due to primarily starting in my league background. But I'm thrilled to be here as a healthcare advocate, joining the committee, and I'll let Barbara now start the program.
Okay, thank you. I want to just make sure that everybody can see. So just those of you I can see, give me a thumbs up if you're seeing the introductory slide, which is for tonight's presentation. And of course, before I begin, Diana already said that you're going to be meeting in your local leagues to reach consensus, but what you're reaching consensus on is a concurrence. So you're going to say whether or not you agree with the proposed or the existing positions. And there are two positions, one on healthcare and one on the financing of healthcare. But tonight, we're just talking about the background information that will inform your discussion when you have your local league consensus. So I want to remind everybody that both our national and New York State League support single-payer health care in their current positions to achieve the goal of affordable and equitable health care for everyone. And should your league decide to concur with either of the new proposed positions, that won't change our league support for single-payer. So single-payer is not a question before us today, and it won't be a question for debate at your consensus meeting. This presentation provides background for the new positions, and it gives highlights from the study materials. But because the study materials are a lot of words and not as many pictures, we had to make some little adaptations to cover the points. And I want to also mention that once we adopt a league position, whether it's an old one or a new one, it never really refers to specific legislation, so that they're written broadly. So you look at, when you're thinking about whether or not your league or the state league should take action on something, you look at the position and then you say, well, how does that proposed legislation meet with our position? Should we support it or should we not? So what we're going to cover tonight is really just the context of the different materials that were in that 50-page document that I'm sure you've all glanced at, if not read. And then we'll have the questions and answers at the end. And the very last thing is the changes that you might see. So what was our context when our study committee began its work 15 months ago? Healthcare was between 1991, when the league first adopted the healthcare positions, and 2019, when this convention said we should do an update. The US GDP almost doubled, but healthcare costs increased 40% faster, now totaling about 3.6 trillion per year in the United States. You can't have universal access without affordable health care. Let's review how private insurance premiums have risen. Navy blue is the employer's share of the premiums. Lighter blue is the employee's share. The cost of premiums has doubled over the past 20 years, with the share paid by workers increasing the fastest. Employers are now shifting even more cost increases onto workers, making health care prohibitively expensive. By selecting plans with narrow networks and cost sharing, the horizontal axis is the past 10 years. The vertical axis is the percent of increase. The bottom blue and black lines are inflation and wages, which have gone up 26%. The green line is premiums, which have gone up 54%. And the orange is cost sharing, which has increased 162%. Remember this orange line. Cost sharing, which is mainly deductibles, but also co-pays and co-insurance and out-of-network charges, everything you pay after you've paid your premiums, plays a huge role in reducing access to health care across New York and the United States. Are we getting better health for our money? Not unimportant health measures like maternal mortality. The horizontal axis is the past 30 years. The vertical axis is deaths per 100,000 live births. The red line shows the US trend. The black lines show trends for peer countries. These countries provide paid maternity leave as well as universal prenatal and postnatal care and delivery with almost no cost sharing. Universal affordable care saves lives and money. I ask again, are we getting better health for our money? Not on life expectancy. The horizontal axis is the per capita cost of health care for each country. The vertical axis is life expectancy at birth. The red line shows the average upward trend. More spending achieves longer lives, with peer countries clustered along and above the red line and paying about $4,000 per person. You can see that our life expectancy is worse despite our paying on average twice as much. But don't these countries all pay really high taxes for their single payer and universal health care? Surprisingly not. We pay more in taxes for health care than our peers. The turquoise is the total cost of health care for peer countries, both from taxes and private spending. The yellow is our health care spending from taxes, with $4,000 in red being the 30% we spend out of pocket. Our public spending on health care exceeds their total spending. But isn't this because Americans use more health care? Americans do see doctors less often. In each of the next charts, the United States is in yellow and the peers are in green. The Japanese, who live 3 years longer than we do, see their doctors 3 times as often. Americans are discharged from hospitals faster than resident peer countries. Americans skip needed care more frequently than their peers. Safe staffing, one change in our proposed positions, is an issue for Americans and for American nurses. Note all of these yellow bars are averages, blending what's true for majority white populations and what's true for marginalized populations. That white dotted line shows the G6 average life expectancy. The G6 residents live longer than white Americans, but a year ago, Black Americans died more than 3.5 years younger than whites, and Native Americans died 5.5 years younger. Today, the pandemic is exacerbating these health disparities. In just the first 6 months of the pandemic, American life expectancy has fallen further 9 months less for whites, almost 2.5 years less for Latinx, and almost 3 years less for Blacks, just between March and September, and still falling. How can 6 months make such a difference? COVID has killed that's by people, that is, Black, Indigenous, people of color. I think you say that BIPOC. Anyhow, at 3 to 5 times the rate of whites and at earlier ages. Think about what happened at meatpacking plants in April. Workers with COVID didn't have access to health care, didn't have sick leave, and risked being fired if they stayed home. So the virus spread across hundreds of plants to tens of thousands of workers and spread out to their communities. Similarly, the spread of disease in nursing homes demonstrates the urgency of safe staffing among vulnerable populations. And safe staffing would also mean that more nurses and caregivers would be in the pool for when health crises hit. Another reason for making it part of our league healthcare position. For workers with job-based insurance, job loss is a double whammy. Loss of income plus loss of health insurance. And loss of insurance affects the whole family and our entire society. When people don't get diagnosed and treated, they continue to spread the virus. Even before the pandemic, lack of insurance killed tens of thousands of Americans. Poor people don't usually get job-based health coverage. Those with higher wages also get job-based health insurance at much higher rates. So why do we hear that Americans depend on their job-based insurance? Well, they used to, but that has changed. 20 years ago, 60% of private sector jobs came with health insurance. Now, only 40% do. Increasingly, employers no longer offer health insurance to newly hired workers. And the gig economy, including Uber, Lyft, Grubhub, Instacart, is speeding this trend. This is one reason our proposed new position favors separating health insurance from employment. If public health for all of us requires regular medical care for all of us, we need to ensure that access to health care is affordable, particularly for those of us where loss of jobs and income means worries about housing and groceries. Let's consider, how are we doing on unemployment? In June 2020, the number of uninsured was at a 50-year peak. I was going to try my laser, but the heck. The dip is what happened after the Affordable Care Act was passed. As you know, the employment recovery is happening at the top, not the bottom of the job scale. Jobs aren't returning for the bottom half of wage earners, especially women, Blacks, Latinx, and people over 50. The most vulnerable among us will not be getting health care with their jobs, if and when they finally get jobs. New York State has expanded Medicaid and a better safety net than other states. So shouldn't having health insurance in New York State ensure affordable health care? 18 months ago, researchers surveyed a statistically significant random sample of several thousand New Yorkers. They concluded that half of New Yorkers delay seeking medical advice. We cut prescriptions. We avoid medical care because we can't afford it. Prior to COVID, we often heard that only 1 million New Yorkers lack health insurance because job-based private health insurance protects us. We rarely hear that 10 million New Yorkers don't have affordable access to health care, harming our overall public health. How can this be? Jan, you need to unmute yourself.
Okay. Okay, I'm going to let Barbara rest her voice for a few minutes. Remember that orange line, how cost sharing has increased 8 times faster than wages in just 2 decades? Private insurance tells us that cost sharing transforms Americans into better shoppers, quote unquote. But research shows us it costs us more and harms our health. When you read the study materials, both the footnoted version of the proposed position and the cost sharing section, you will see why we favor and disfavor specific cost control methods. One quick example to illustrate the international comparison at the bottom of the page. Most of us know that diabetes and asthma can be almost fully controlled by medication and monitoring. But Americans forego treatment and medications because they can't afford to pay for insulin, inhalers, and monitoring supplies. So too often they end up hospitalized with increasingly expensive and severe health problems. Eventually, Medicaid pays for those who become medically indigent. Not getting medications we need increases profits for the private insurers. Getting severely sick patients off their rolls saves them even more. Can private insurance really be so financially expensive for Americans? Compares the healthcare costs of the US, the turquoise line, and Canada, the yellow line, 60 years. Before 1960, the two countries had similar health metrics like life expectancy and costs. The arrows show when Canada changed from multi-payer private insurance, publicly funded single-payer insurance. Canada now controls its healthcare costs far more effectively than we do. Notice how the gap between the two lines is growing, and their health metrics are much better. But does this really explain much? Let's look at similar trends within the US. Here's the orange line that shows the cost of private insurance doubling over the past 13 years, compared to Medicaid's and Medicare's 60% increase. Of course, this chart doesn't show that over that period, 1/3 of Medicare enrollees moved into private insurance Medicare Advantage plans. What explains this difference? Profits and administrative costs. Medicare has overhead of about 2%, while private insurers have been limited to overhead of 20% by the Affordable Care Act, whereas Medicare Advantage plans have overhead about 14%. Worse, insurance overhead actually increases providers' costs. Billing and prior authorizations and appealing denials and all add costs without adding care. Think about the number of billing people in your doctor's office. Did you also know that doctors have to spend about 2 hours on private authorizations, prior authorization, billing appeals, and desk work for every hour they spend with patients? That's one reason we won't experience a physician shortage if we switch to a single-payer plan, and why most physicians now support switching to single-payer plans. So do multi-payer administrative costs explain why American healthcare costs so much? Let's look at Canada again. We spend about $3,000 more per person than Canada on administration, a big piece of our excessive total spending. So how much do we spend on healthcare in US? A lot. About $300 billion a year in just New York State alone. The biggest funder of this is the federal government, with taxes in showing yellow, orange, and red, totaling about 60%. If we were to move to a single-payer system, we would need segments. The insurance premiums and your out-of-pocket with county share of
You know,
Medicaid, it now pays.
And
So what? Yeah.
Can you start over
What?
on that one because your internet was so bad?
Oh, sure. Okay.
I
This
think
is
it's
the cost for New York State.
numbers. Yeah.
Thank you. We spend about $3,000 more per person than Canada on administration, a big piece of our excessive total spending. So how much do we spend on healthcare? The pie chart shows us it's a lot. About $300 billion a year in New York State alone. The biggest funder of it is the federal government, with taxes shown here in yellow, orange, and red, totaling about 60% of that total. If we move to a single-payer system, we would need to replace the green segments, the insurance premiums, and our out-of-pocket payments. Replace those with tax dollars. And New York Health would also replace the county share of Medicaid it now pays. So what is single payer? First, single payer comes in different flavors. Usually they cover everyone in a specific group for specifically defined benefits, and providers invoice one payer, the government, at a standardized rates. So providers don't need lots of staff for billing because everyone has the same coverage. American examples of single payer include original Medicaid system, Indian health services. But not all single payer systems are the same. There's a skinny single payer. Many of us are familiar with the in and outs of Medicare today. It's publicly funded, but privately delivered by our doctors. It's great insurance, but it's a bit complex. Some gaps, premiums, and trade-offs. Example. Let's look at New York Health, which is a model our study committee was instructed to use when considering single payer. Just as the 1990 League Study Committee looked at what was called Unicare, a New York State single payer bill only one person on our 2019 study committee even remembered. New York, the act would be universal for all of New York State, comprehensive and administratively simple. It would replace for-profit insurance. Like Medicare, its administrative overhead would be under 3%. Also, like Medicare, it would be publicly funded but privately delivered. But will shifting to New York Health end Medicare? That's a worry for even some members of our study committee. Many reading their Medicare benefits follow them to Florida or on visits to family members. That would still be true. In New York State, a New York health card would give better coverage without gaps, no premiums or cost sharing, and far less hassle, with every New York State doctor and hospital in network. Out of state, people would still use their original Medicare card, which all providers can accept, with New York Health as their backup. But as we often hear, is New York Health socialized medicine? No, New York Health would be like Medicare, publicly funded but privately delivered. Unlike the VA or Indian Health Services, New York State would not own or hire doctors. So we've seen that single payer cuts administrative waste, but would it improve public health? This chart shows along its horizontal axis American ages from birth to age 99. The vertical axis shows the US rank in life expectancy for each age. At birth, we're the lowest of the peer countries. But by age 70 to 75, we begin living longer. Within a decade, living as long as the top ranked Japanese and Spanish. How can this be? Amazingly, New York universal health with affordable access dramatically includes public health, improves, even for those who have spent 6 decades foregoing care. It's surprising to learn that regularly seeing a doctor, taking prescriptions, and getting treatments lengthens lives. So how would New Yorkers pay for single payer, and how much more would it cost than now? The pie chart on the left is the one you've seen before. Current spending of $300 billion, 60% coming from taxes. If we were to switch to New York Health, the chart on the right, that would mean changing how we pay for the green segments on the left. The political difficulty is that switching to New York Health requires new New York State taxes of about $160 billion. They would replace the $171 billion New Yorkers currently spend on premiums, out-of-pocket costs, and their counties on Medicaid. It would save us almost $11 billion per year over what we spend now, with better cost control over time, as we saw on those trend lines for the Canadian health costs. The new taxes would be paid into the New York Health Trust, not to general funds, just as our Medicare taxes go into the Medicare Trust. The new proposed position says that in the absence of a national universal healthcare system, New York State could assume that role for our state. But does New York State have the population and the resources to run a single payer system? If New York were a country, it would be the 12th largest economy in the world, about the size of Canada's economy, with a population about the size of Taiwan. Vermont passed a law calling for a single payer plan, but it never designed that plan. Colorado created a ballot initiative for a single payer plan, but that plan would have prevented legal abortions, so it was not implemented. 18 states now have single payer legislation under consideration. Small states are considering regional systems. But should a state be able to create its own single payer system? We live in a federal system. Federal and state governments share sovereignty. As Justice Brandeis wrote 90 years ago, because we live in a federal system, a single courageous state may, if its citizens choose, serve as a laboratory of democracy. We've seen this in New York State when we led the way in allowing legal abortion and was the first state to require drivers to wear seatbelts. More recently, expanded Medicaid and drug legalization increased after early adopting states let other states learn from their experiences, or not. We've also seen this in Canada, another federal system with 10 provinces and 3 territories, where one province acted alone and all of Canada and the AMA initially campaigning against it. In Saskatchewan, a Canadian province with 5% of our population in New York and 5% of our GDP, yet 5,000 times as much land area, implemented a single-payer health care in 1962. A year of record-breaking advertising vehemently opposed it. It was paid for by the AMA, and doctors said they would strike. Regardless, the newly elected head of that province, Tommy Douglas, pushed single-payer into existence. Within 6 months, the tide had turned. Within 4 years, the federal government passed laws supporting provincial single-payer plans, and within 10 adopted single-payer. So before we take questions, I want to mention that the study materials and the changes in new positions. The study materials specifically, our update committee is very proud of the study materials, which, as Barb explained earlier, it took more than a year to do the research and put all that together. Please read them, or at the very least look them over before the consensus meetings. Especially pay attention to the footnoted positions on pages 31 through 35 of the 50-page document. The footnotes there give reasons for the changes that the committee has proposed. So what are these key changes between the current and proposed positions that you will be considering at your consensus meeting? Barb?
The sentences in the 2 positions have been reorganized. These are the key content changes. So you can't just hold the 2 positions right next to each other. So ensuring health care for the vulnerable, including to protect overall public health. So we particularly are concerned about rural and inner city urban populations and certain disadvantaged groups. Then the other one is including vision, dental, hearing, and long-term care as essential care. Actually, the position says ideally including that because of a little conflict with this national position. Favoring healthcare that is affordable for everyone, favoring the separation of health insurance from employment status, specifying cost control methods and feasibility criteria that have demonstrated effectiveness, recognizing single payer as viable and desirable, not just acceptable, adjusting language on the New York State role in healthcare. The proposed positions would not change national and state league support for universal, affordable, equitable health care funded by taxes, characteristics of single payer approaches. So now that you know all that, What was the question?
So what I'm going to do, thank you, you stopped your screen sharing. And I'm going to, for the moment, remove the spotlight. And so everybody should be on gallery view. And if you would, could you try to raise your hand or unmute yourself, and I'll recognize you for your questions.
There's one question in the chat asking about reimbursement rates for medical providers. So we'll get discussion started with that one from Kim.
Okay, Kim, I think you're asking about if the proposed New York Health Act were to pass, what would the reimbursement rates be like? Is that the question?
Yes. So I guess my question would be, would doctors see a decline in their reimbursement rates? Like, is this going to make it harder for them to maintain their own practices? I know there's a benefit to the admin piece, but does it change the reimbursement rates?
If the plan is that the reimbursement rates would be similar to the reimbursement rates that we now see that private insurers do pay, but we think there will be some skewing that maybe the very highest rates for some specialties may not be as high, and that we would be paying more for primary care. So that, and we see that particularly as an advantage in rural areas, because now in rural areas, so many patients are on Medicaid, and Medicaid doesn't really cover the cost. So it makes it hard to get providers in those areas.
Mhm. Yeah, remember too that we said that for every patient, the doctor may spend 2 hours on the phone, on hold, trying to appeal for a referral or a denial or some other kind of treatment that he or she feels the patient needs. And also all those back office people. So that money will become available, and the doctors can become more productive, perhaps seeing more people. I have a doctor in my family who comes home at night and has to sit and work on his notes, because there's just so much to catch up on. Yeah.
Helen.
Yes, I spent 35 years in the Canadian system, healthcare system, and I have to say, when I came here, I was shocked because of the paperwork. No, no change in the quality of care. But that paperwork, and coming from an insurance company, which is what I worked for, I can see how much that paperwork is costing us, because you have double this and double that and everything. I'm pleased to see that the Canadian system is now proving itself to be worth it, because I felt all along that it was, and I was really missing it, because I think if we get universal health care, it'll be fantastic. People won't, the doctors, I believe, because I was there when it switched over too, from being, an insurance-based into a universal care, and the doctors did. And our doctors might not like it either, but it happened, and I seemed to work for me anyway. And all this rumor about you don't get the kind of care you want, I mean, it's ridiculous, because I raised my family and I had no problems at all. So there's probably the odd story out there, but didn't happen to me. So 35 years.
So I think one of the things, Helen, that we see now is that although initially the AMA was very, very much against it, and they paid for a lot of campaigns, they're they haven't come out in favor of it, but they have, they're neutral on it now.
Yeah, that's good.
And and a lot of physicians don't belong to the AMA anymore, and they tend to be much more supportive of it, because it's a very frustrating thing when they've gone to school and what they would really like to do is to treat patients and
Right.
figure out what's the matter with them and that kind of thing. And instead they spend their day, or half of it anyway, looking for how to get reimbursed, how to get care for somebody that they want them to have a certain kind of care, and they have to argue with the company.
Right,
Mhm.
right.
And the people they argue with at the company are usually not at the insurance company are usually not the doctors. Mhm.
Great.
There's another major advocacy group called Physicians for a National Health Program, PNHP. If you have interest, you could just look to see what their position is on single payer. Mhm.
Um,
I think Betty Ann has a question.
Yes,
Betty
I
Ann
do.
King.
Would you still be able to choose your doctor? And I know that some people, currently who are on Medicaid or Medicare, in order to get a particular service, that they have to travel long distances because not everyone would accept it. Of course, I know that that would be different, but would the choices still be there?
The one thing that needs to be worked out, and there is, plans to do that, is that if you currently get your health care out of state, and I know a lot of people in Plattsburgh probably go to Burlington. So you're not right at a border where people might generally see most of their physicians in another state. So they have to work out those arrangements with those people, but within state, every provider would be in.
Okay.
Right. Mhm. And the thing is, we have a difference now that not everybody understands between Medicare and Medicare Advantage, which is a managed care for-profit insurance plan. Whereas original Medicare, you can always choose your own provider, and you're also entitled to a second opinion in original Medicare.
Some other questions? Go ahead and unmute yourself.
I think
I
there was
had a
one in the chat. Yeah.
I had a small technical question. Back at the beginning of the slides,
Yeah.
you mentioned peer countries. I didn't get how you defined peer.
Well, in some of those slides, they're slightly differently defined. A lot of them are the Organization of Economic.
OECD. Right.
Yeah, OECD countries. So, and on some of the slides they were listed, but they are essentially the Western European countries, Japan, New Zealand, Australia, those kinds of countries.
Mhm. Mhm. Countries that have their own universal health plans.
So, we're rather unique in not having a universal health care plan in the world, I think.
Yeah, we are.
Mhm. Right. The question from the chat, Barbara, has to do with, is it true that there would be no co-pays or deductibles under the proposed New York Health Act?
And the answer is absolutely yes. There would be no charge. You just show your card. So you
Great.
don't need anything else. And there are some things that need to be worked out. Like if you work in New York State, but you live in New Jersey, or
Vice versa.
and vice versa. So there are some of those things that
Mhm.
will have to be worked out in the legislation and in the negotiations after that.
Right. And the other thing we covered was about the snowbirds who go south for the warmth in the winter. Medicare would still continue to cover those folks. New York State Health Act would become a secondary payer in those cases. Sorry. Barbara, I think I interrupted
Yeah,
you. I'm
well, I
sorry.
was going to reply to Kim Reich's question. She asked if I would share these slides for them to use in their consensus meetings. And no, because not that I wouldn't share these slides with you if you wanted to do another meeting like this, but there is a PowerPoint that's available to every league. It's on the PDF of the PowerPoint is on the State League's website, and just by requesting it from them, because they think it takes up too much space on their website and slows the whole website down to post a PowerPoint. But the PowerPoint that you would want to use at your consensus meeting is the same as in the discussion guide. It's set up a little bit differently. So you see things from the current position, and then features of the new proposal, and then there's a couple of questions that go with that. So that's what you really need to use at your concurrence meeting. One thing I would suggest is that if there's only really one slide and one question about the healthcare position, the old one and the new one. So I would suggest that although the PowerPoint has you then wait till the end to say, do you accept that or not? I think it's better to just
Yeah.
say after you've done
yeah.
whether about that position, and then move on to
Mhm.
the financing of healthcare position.
Right. It's three columns of
Any other
comparison as Barb is describing to you. Yeah. And it goes through entirely both of the two proposed positions, health and healthcare financing, very specifically to show you how the wording of the new position is different from the old one and why.
And everybody, whether you're presenting or not, should look at the discussion guide, because those things are right there. And then somebody from your league, or if you want to, in sort of have extra insurance, have two people download it so that if something happens when one person is trying to share their screen, the other person can.
And it also doesn't say that if your leagues become interested in this subject, that you can't organize additional meetings just out of interest, very focused on some of these questions to help everybody understand everything better, and your communities perhaps as well.
Yeah, and certainly the slides that we use tonight would be available if you want to use, to have, say, a public meeting showing those kinds of things.
Mhm. Right.
A couple more questions in the chat. Would there be limits on elective procedures? Would people be able to purchase additional private insurance to cover those expenses? And then also one about, would there be a need for Medicare Advantage plans under the New York Health Act?
There would not be a need for Medicare Advantage plans. Okay, New York Health would be the backup provider for that. I'm not sure just if they're going to pay the premiums out of, I don't think so. I think they're going to actually just be like now, have one insurance and then the other one is, the second payer. Usually Medicare is the very last payer in New York State. So that's that one. And
Yeah.
I think, Kim, the question about limits on elective procedures. First of all, people would not pay insurance, and it wouldn't be allowed to be sold for the services that are covered by the plan, which is pretty much everything except, like sort of luxury things. If you wanted to ensure that you had a private room, even though it wasn't medically necessary. If you wanted, I think probably some cosmetic surgery would not be, although some would be,
Yeah.
like if you were in an automobile accident, that kind of cosmetic surgery would be available.
Mhm. Yeah.
So there wouldn't be that extra kind of insurance, and it wouldn't be allowed to be sold because that's the thing that adds so much to the administrative cost.
Yeah. See, Medicare Advantage plans advertise themselves as, well, you're going to get this free, but what the insurance companies don't tell you is that therefore we, all the taxpayers, are going to pay more for your insurance because the insurance companies make a bit more profit off of the people who sign up for Medicare Advantage. You surrender some of your freedom and flexibility when you join Medicare Advantage plan, but you get some other things that are supposedly included. So.
Now, there's a sort of subtlety to Kim Reich's question. Does single payer necessarily mean no co-pays? And I think that's that's a question that came up because Medicare is a single payer system. So we were talking about the New York Health Act, which is a specific kind of single payer. And just an example, who knows? So we saw with like Unicare, we thought maybe that would go in the 90s. And now nobody even, barely remembers what it was about. And it was a very different system. It was much more like the French system, where they have insurance companies, but they all provide the very same coverage. And I think there's a negotiated part. I don't know why they have the insurance company, but they're the administrator.
See, that's where a legislature would play the role that Congress played when it set up Medicare with certain prohibitions and certain things that, might not be in a pure single payer system, but that's the Medicare system that we have based on what Congress enacted. And, there have been a few changes, and certainly the Affordable Care Act made many changes in 2010. It's like we get free shots and free annual checkups and so forth, other things. But there's a lot. That's why this is such a complex subject. We said we really want leagues to have at least 2 meetings on it, one to be the educational and then one to be the actual consensus concurrence time for discussion.
Well, thank you. And I know Helen posted something in the chat because we also got some separate reports. And one is, the AMA may not be campaigning against it now. They may be more neutral, but we can expect pushback from places like the Chamber of Commerce, perhaps.
Small Business Association.
I'm sorry,
What'd you say, Barb?
Small Business Association, all of those groups. Although, in fact, single payer would be an advantage for small businesses, many of whom can't buy good health insurance, even for themselves. Like it's maybe a small business with 3 employees, one of whom is the owner, and yet they don't get good insurance because it's so prohibitive that way.
And if somebody has a disabling condition, their insurance could be a whole lot more expensive, again, to price them out of the market the way, the private market has worked traditionally over time. So there's a lot of to do, but that's why someone like from Physicians for a National Health Program or some other organization, you could put a panel together with different questions and different viewpoints and then listen to your local folks. Every time I go to a doctor, I spend part of my time, we talk about healthcare reform because they are so ready and eager for it, so
Okay, well, I think, well, is there one last question that anyone has? If you do, unmute yourself. We'll take one more question. Okay. All
I'd
right.
like to say thank you so much, Barb and Jan. This was fabulous. Thank you so much. I can tell you put a lot of work into it and we really appreciate it. Thank you.
Fun to share. Thank you
Yeah.
for inviting us.
Yeah.
So yes, so Barb from Saratoga County and Jan from Huntington, Long Island, and all of our guests from Geneva and Jefferson and St.
Yes.
Lawrence and Cattaraugus, Allegheny.
Mhm.
So what we will do, if it's okay, I will stop recording and I will forward this. Is that okay to forward the recording to our membership?
Yeah, and it would be nice because I see we only have a sampling of your members, and maybe it's easier for them than reading through the materials. But I do think that when they come to your concurrence meeting, that they should have printed out the actual positions that have the footnotes, the new ones and the old ones, so that they can, because
Mm.
we sort of paraphrase in the slide discussion.
Mhm.
And it would be nice for them to have looked at that.
Thank you.
Mhm.
Well, we plan to have our meeting sometime in February, date to be determined.
Yes.
And again, we wish you well and we appreciate the really tremendous amount of work and labor that went into the state level committee to look at this. So thank you. And I'm going to invite North Country members to stay just for a few minutes if you can. And everyone else, you are free to move about your house.
Thank you.
Thanks so much.
Thank you all for being here. It's great.